past chairman of Imaging Science Committee FOXI, deliberating her expertise and inputs on the topic, approach to hydrops, immune and non-immune. Mr. Arun, can we start the recording?
Prayer song prayer
So before that, may I now request everyone who is logged in to kindly observe 1 minute of silence in the memory of the medical students who lost their lives in the recent aircraft disaster. Let us honor their lives.
Sonia, first prayer start with the prayer first.
Okay. Arun sir? Thank you. Invoking the blessings of the Almighty and move ahead, but there's never to forget to observe 1 minute of silence for those medical students who lost their lives in the recent aircraft disaster. Let us honor their lives, their aspirations, their dedication, and they had such a noble vision to our noble profession of medicine.
And also the personnel who also lost their life in the plane crash, please.
Yes,
so many of the doctors were there in that plane also. So
yes.
Let's all, on behalf of KCOG and KCOG, observe 1 minute of silence.
Yes, madam.
Thank you. Let's now move forward with today's webinar with a sense of purpose and renewed commitment. I now invite Dr. Suma, Professor, Unit Head, JSS Medical College, to take over and continue with the next part of the program.
Thank you, Sonia. Thank you, Bellad sir, for giving me this opportunity. Yellarigu nanna namaskaralu. Good evening, everyone. Seeking the blessings of all the teachers who have logged in over here. Now I proceed with welcoming all the office bearers of KCOG and KCOG. At the outset, first I would like to welcome Dr. Nagraj sir, the patron of KCOG, and Hiremat sir, who is the chief patron of KCOG, and Bellad sir, who is the dean of Karnataka College of Obstetricians and Gynecologists, and Dr. Vidya Bhatt, who is the chairperson. In her absence, I will be welcoming her. And I also welcome Dr. Durgadas Asrana, who is the present president of KCOG, and Dr. Bharti Rashekar ma'am, who is the past president of KCOG, and also at present she is the chairperson of Perinatal Perinatology Committee of FOXI. I also welcome Dr. Rajeshri Palladi, who is the past secretary KCOG, and she is the present president-elect of KCOG. I also welcome Dr. Shobha Gudi ma'am. Actually, I'm not seeing her. She might log in at a later date.
Yeah, she is logged in. She's logged in. Yes, ma'am.
Sure. I welcome Shobha.
I'm there, Suma.
Okay, ma'am. Okay, ma'am. I welcome
Thanks
Shobha
for the
Gudi ma'am,
welcome.
who
You
is
can proceed.
secretary
Yeah.
of KCOG, and Dr. Shobha Bembalgi ma'am, who is the treasurer of KCOG. And I also welcome Dr. Bela Bhatt, who is the speaker of today's program. I also welcome all the delegates who have logged in for today's webinar. And without wasting much time, we'll move on to the
And Suma, also Suma, also Dr. Suman Gaddi, treasurer of KCOG.
Yes.
Sorry, ma'am. I also welcome Suman Gaddi, ma'am, who is the treasurer of KCOG, past treasurer of KCOG, and now she is the treasurer of KCOG. And now we will move on to the most awaited session of today. And I request the chairpersons of today's program, Dr. Bharti Shekhar ma'am, Bharti Rajshekhar ma'am, and Dr. Rajashri madam to take over the session and proceed with the program.
Yes.
Mr. Arun, please display the CV of Bharti ma'am and Rajashri ma'am.
I think Dr. Suma, Dr. Rajeshri, and Dr. Bharti are known to most of the delegates over here. Let
Of
us
course,
not
ma'am,
waste
of course.
precious academic time, and I think we should move ahead. So anyway,
Yeah.
thank you for the introduction. And now the non-immune hydrops is what the topic has been chosen by the KCOG team. And we have a very eminent speaker, Dr. Bela Bhatt, who will be speaking on this topic. And generally, we are all talking about hydrops fetalis and the Rh isoimmunization syndrome. But this non-immune hydrops is a very complicated scenario. And the etiology very often is not known sometimes. And sometimes a very uneventful pregnancy going on till the second trimester. And suddenly, out of the blue, we see that the baby has developed hydrops. And then clinching the diagnosis of what is the etiology for hydrops. And with the advent of fetal medicine, we can effectively try to reduce the neonatal morbidity and as well as the mortality in non-immune hydrops. And I'm sure now Dr. Bela Bhatt will be speaking to us on this very important topic. I thank Dr. Belad, the Dean of KCOG, and the entire team of KCOG, Dr. Managraj, Dr. M.G. Hiremat, for giving me the opportunity to chair this very important session. And this is a very less discussed topic. And I really appreciate Dr. Bellad for, of course, as a trainer, teacher of teachers, he has chosen this very important topic because even as experienced clinicians, even today, when we come across a case of non-immune eye drops, we are perplexed and we have to start referring and consulting our colleagues to find out how we can proceed. And I'm sure the youngsters who have logged in are definitely going to benefit from the important discussions we're going to have in the next 1 hour or so. Thank you very much for giving me the opportunity to be here.
My pranamams to everybody. And indeed, it's a pleasure and an honor to be a chairperson for such a wonderful topic and by a renowned faculty who has been a chairperson for the Foxy Imaging Science Committee for the year 2021 and 24. Dr. Bela Bhatt is a consultant at Bela's Women's Hospital and Fetal Medicine Center, Mumbai. And she's a certified sonologist by the FMF Foundation for the Fetal Abnormalities and author of the book, The Vital Skill Ultrasound in Obstetrics and Gynecology. Dr. Bela is also a recognized trainer for ultrasound in OBGYN and has been the secretary for the Mumbai AFG and managing committee member for ISAT. Many awards to her accolades. Dr. C.S. John Award, the Foxy also has awarded her for the talent in 2018. Wonder Foxy Award 2019, champion of ISPAT Award 2021, Foxy Superstar Award 2021, and Foxy Dheera Award for the year 2022, Foxy Badlav Achiever Award and UNICEF Appreciation Award, Foxy ICOG Award, and Foxy Talent and Imaging Science Committee Award. So with so many awards to her accolades, I'm sure that we are going to have a very wonderful discussion on this important topic as mentioned. And I'm grateful for giving me this opportunity to chair this session to Dr. Bella, to KCOG faculty and everybody. Please, over to you, Dr. Bela.
Thank you so much for those kind words of introduction, Dr. Bharati and Dr. Rajeshri. So, well, at the outset, I would like to quickly thank all the office bearers of KCOG and KCOG. The Chief Patron, Dr. Hiremat, Dean, Dr. Bellad, Chairperson, Dr. Vidya Bhatt, Secretary, Dr. Sonia, who has been communicating with me for the same, Treasurer, Dr. Suman, and the KCOG office bearers, patrons, Dr. Nagaraj sir, President Dr. Durga Das, past President Dr. Bharti Rajshekhar, President-elect Dr. Rajeshri Paladi, General Secretary Dr. Shobha Gudi, and Treasurer Dr. Shobha for giving me this opportunity to be here to discuss on this very important aspect, approach to hydros vitalis. Hope my screen is seen.
Yes, ma'am. Yes, ma'am.
Okay. Now, the topic given to me was approach to hydros vitalis. So I'll quickly just go through the definition and the immune part of the hydros vitalis. And then, of course, as far as non-immune hydros vitalis is one, I'm going to share some of the cases so that we can learn from the cases better. So we all know that hydros vitalis is nothing but abnormal accumulation of serous fluid in at least two body compartments or cavity. So subcutaneous edema with even one body cavity collection is known as hydros vitalis, and it may be associated with placentomegaly with the prevalence of 1 in 1500 to 1 in 4000 births. Now, we know there are two types of hydros. One is immune and the non-immune. The immune one is because of the Rh negative mother with hemolytic antibodies. But what is important here to understand is that as it was mentioned very much by Dr. Hiremat that these days we want to concentrate more on non-immune. Why? Because the immune cause has reduced to 10 to 20% because of NTD. But most of the cases that we are now seeing are non-immune hydros because of the better skill development in ultrasound, better machines, and being able to find out the causes for non-immune hydros, to also being able to save many of these fetuses. That's the reason now the focus it has shifted to non-immune hydrops as well. Of course, we are dealing with immune hydrops still, but the focus is also on the non-immune hydrops. So, quickly, as we know that whenever there is Rh negative mother, and if the fetus is Rh positive, what happens is there is isoimmunization. So the mother will develop, because of these RBCs of the fetus going into maternal circulation, antibodies develop in the mother, and these antibodies are going to remain lifelong in maternal circulation, and the critical sensitizing volume for the same could be as low as 0.1 to 30 ml, right? And these antibodies which persist for life in the mother. So in the next pregnancy, if the baby is Rh positive, this will cross across the placenta and will lead to hemolytic disease in the baby. And that's how the more severe the anemia, the hydrops can develop. Okay. That's how, that's a basic mechanism. Now, as I said, 1968, there was introduction of NTD, and with that, there was reduction in the incidence of immune hydrops. So without any NTD, the possibility of sensitization of the mother was 15%, which was reduced by the postpartum NTD to 2%. And now, with the antepartum NTD at 28 weeks, it has further reduced to 0.1%. So to a great extent, we have been able to control this. But still, why are we discussing about even immune hydrops? Because of the improper NTD prophylaxis. We all know so many patients are taking MTP pills in first trimester from various places, and the blood group may not have been known, and they take it, and there may have been sensitizing event. First trimester events, bleeding may go unnoticed. Inadequate dose in multiple pregnancy, C-section, where Kleber-Betke test is ideally should be done, but is not being done. Antenatal NTD is yet not routinely given at every places, and poor compliance with the second dose, that is a postpartum dose. And also in the improper way of administration. If the NTD should not be frozen, but the temperature maintained should be 2 to 8 degree. It should not be given intragluteal, but intradeltoid, inadequate dose, non-recognition. There can be some antigens other than non-D which are not recognized, and lack of awareness of staff. All these are the reasons still why we are finding so many cases of even immune hydrops. Now, the spectrum can be from just mild anemia to hydrops. But our aim is to intervene in between, pick up the cases which are treatable, and that's possible these days with the help of ultrasound and Dopplers. The first step to know if the mother is isoimmunized already because of the past event is to do an indirect Coombs test, in which it test for the free circulating antibodies in the mother, as against direct test, which is done with the either cord blood or fetal blood, in which antibodies bound with the fetal RBCs are picked up. But we are in pregnancy interested with the ICT or indirect Holmes test. Now, when to start monitoring? So management is different for isoimmunized versus previously affected pregnancy. When ICT is positive, then it all depends whether the NTD titer is below the critical titer or above the critical titer. So obviously the next question would be, what is a critical titer? So it's a titer above which fetal hemolytic disease occurs, and it's a lab specific titer. But in general, for a gel method, it is around 1 in 64, and for a tube method, 1 in 8. More commonly, gel method is being used. Now, if the titer is below, NTD titer is below this critical titer, then we can repeat titers 4 weekly, and then if it reaches near critical titer, we can repeat it 2 weekly. But what if the NTD titer is above the critical titer? We know that now the hemolytic disease has already started in the baby. Then we need to monitor with this very useful non-invasive method, which is middle cerebral artery Doppler, right? And this is very sonologist friendly. And what we look at is the peak systolic velocity in the middle cerebral artery. And the mechanism why, so what happens in the fetal anemia is the middle cerebral artery PSV increases. So why does it increase? Because in fetal anemia, in the response to the anemic hypoxia, there is increase in the stroke volume, increase in the cardiac output, leading to hyperdynamic circulation. That's one thing. Secondly, there is decreased blood viscosity because of anemia, and both this put together increases the peak systolic velocity of middle cerebral artery. And also there is increased venous return from legs due to decreased viscosity. Now, when we say that the MCA-PSV is high, it goes beyond 1.5 MOM, then it tells us that it is severe anemia in the fetus, and therefore it needs intrauterine transfusion. So that's an indication. MCA-PSV more than 1.5 MOM for that gestational week. So this, the MCA-PSV Doppler is one non-invasive method which has replaced the invasive method which was being used in past from the amniotic fluid. Now, the next question would be, how do we come to know about MCA-PSV MOMs? So, well, for every obstetrician, every sonologist, these calculators are available on perinatology.com, FMF UK calculators, wherein you can just put in the values of the gestational age and the MCA-PSV, and it will tell you whether it is going beyond 1.5 MOM or not. And there are some charts also available on which you can see. Plus, if you see roughly, if the MCA-PSV is almost more than double than the weeks of gestation, that also roughly tells you that this is more than 1.5 MOM. And then you can plan for the intrauterine transfusion. MCA-PSV, we can start looking at from the 16 to 18 weeks and till 35 weeks, after which the false positive rate may increase. Now, as far as management is concerned, if the MCA-PSV is less than 1.5 MOM, we can wait, keep on repeating MCA-PSV and deliver at 37 to 38 weeks. If the MCA-PSV MOM is more than 1.5 and it is more than 35 weeks, again we can deliver after steroid. And if it is before 35 weeks, more than 1.5 MOM, then we need to do intrauterine transfusion and monitor accordingly. So that was quickly in a nutshell about the immune hydrops. As everybody is interested in discussing about non-immune hydrops fetalis, I'm going to throw more light on this with case discussion. Now, as we all know, there is changing scenario in non-immune hydrops fetalis. Now, we must remember that non-immune hydrops fetalis in itself is not a disease, but just a symptom of underlying problem. And there can be many problems starting from anemia, infection, chromosomal heart failure, aviations, metabolic disorders, neuromuscular brain anomaly, mediastinal defects, hypoproteinemia, genetic syndrome. But the common ones are genetic cause, Turner, Down syndrome, cardiac cause, lung defect, severe anemia because of parvo B19, alpha thalassemia, or torch infection. So, how do we start investigating a case of non-immune hydrops? Of course, the history take is extremely important because we need to look at the family, the pedigree charting, the genetic cause, any other hormonal cause. We look at the blood investigation, CBC, the indirect Skumsda's maternal antibody screening to rule out the immune cause, thyroid function test, torch infection screening, fetal detailed ultrasound scanning, which is extremely, extremely important because it's going to throw a lot of light about finding out the cause of it, in which we look at the fetal heart rate, fetal echocardiography, Doppler studies. In case-based cases, amniocentesis for karyotype and microarray and fetal blood sampling. And on the ultrasound, there are pointers. If there is heart block like Sjogren syndrome or SLE, there can be bradycardia, and trisomy 21 or cardiac arrhythmia. You'll find tachycardia. MCA-PSC more than 1.5 MOM could be because of fetal anemia, because of parvo B19, alpha thalassemia, right? So having this knowledge about the cause and the basic investigations, let's have a look at some of the cases. This was 12 weeks, 5 days pregnancy, non-consanguineous marriage, 33 years old, third gravida, previous one missed abortion, second full-term delivery, female of 8 years. She was Rh positive, and at nuchal scan, this was the picture. As you can see, there is subcutaneous edema with some ascites and pleural effusion. This was a case of hydrops. The cardia looked okay though, and the other markers were not there. Now, this particular patient, whenever there is a hydrops, as we said, we would always try and find out the causes. First thing, we need to rule out the genetic cause. The patient was told to rule out the genetic cause, but they were not keen on doing it antenatally. They wanted the termination of pregnancy, but the tissue was sent for genetic testing because we are interested in finding out the cause. And the microarray of the fetal tissue did show trisomy 21. So the cause here was Down syndrome for the hydrops. Now, why is it important to find out the cause? Because it will help on prognosticating for the next pregnancy. Suppose instead of this, there is some genetic syndrome, which is either autosomal recessive or autosomal dominant. We know that we need to follow up in next pregnancy. At 3 months after nuchal scan, we need to do the sampling and the testing for the same mutation which is found in the fetus, and then proved that the parents are also carriers. So trio testing should have been done before planning next pregnancy, and that way we'll be able to help the patient. Now, the other case, non-consanguineous marriage, 25 years, primary gravida, Rh positive. Again, here you can see there is a lot of subcutaneous edema, and also you'll be able to appreciate there is some pleural effusion which is also there. The heart here looked, cardia was looking, showing one AVSD, that was a cardiac defect, which was also associated with this non-immune hydrops fetalis. So cardiac anomaly along with the increased nuchal translucency and hydrops. So obviously, again, the patient was, whenever there is combination of cardiac anomaly and non-immune hydrops, the first thing we need to rule out is the genetic cause. Patient was counseled about the same, and the genetic study was done, and it proved to be a Turner's syndrome. So again, patient comes to know about the cause of it, and then we'll be able to help the patient to prognosticate for the next pregnancy. Third case, consanguineous marriage. Now, this is a very, very interesting case. There was a history of one affected child in the sense that they said the previous child on maternal side had some neuromuscular disorder. This particular patient had bad obstetric history, third gravida, first male died in 15 minutes, no papers available. Second, full-term delivery, female died after 4 days. Just one paper was there in which on ultrasound it was mentioned suspected having arthrogryposis. That's it, no genetic testing done. Third time patient came for ultrasound, and on ultrasound it was showing the hydrops fetalis, but not just hydrops. Along with that, as you can see very well in the image as well as the 3D image and the clip, there was the fixed flexion deformity in the upper limbs as well as lower limbs, and that was persistently there for 20 to 30 minutes of scan time. Okay, there was no other cardiac or any other structure anomaly seen. So it was for sure that there is some neuromuscular disorder which is giving rise to recurrent same kind of deformity in all the fetuses. So what was counseled to the patient was, this patient was referred to me from a government hospital. So it was counseled to the patient that yes, they didn't want to continue because there was major neuromuscular disorder. They were counseled that it's very important this time that the genetic testing of fetus as well as parents should be done even after termination. So they did terminate the pregnancy, but this time the trio exome sequencing was done. That means fetus and both parents exome sequencing was done, and it did pick up the anomaly which was COSY-related defect in the proband, that is the fetus. You can see here very well homozygous state, and both the parents were also found to be carrier for the same mutation which was found in the fetus. So it was correlated that the mutation which was found in the fetus was carried by both the parents. So this was a autosomal recessive disorder, arthrogryposis, caused by a COSY-related disease, and therefore every pregnancy there was 25% chance of recurrence of the same genetic disease. So in the next pregnancy, now this is very important that we do this workup before planning next pregnancy, because if the patient directly comes in next pregnancy, this genetic test takes almost 6 weeks. Exome sequencing takes 6 weeks to give results. So if you do it in the pregnancy, the precious third month time when we can do the anti-scan followed by CVS is lost. So if we want to help our patients, it is better that we investigate them before the pregnancy. So in next pregnancy, when she came to me right from early pregnancy, we had the genetic defect in hand. So I did her nuchal scan followed by Korean villus sampling and sent the tissue for the same mutation which was found in the fetus as well as in the parents. And fortunately, this time the same mutation was not found in the fetus. So the fetus was not affected. They continued with the pregnancy and delivered a healthy baby at term. So that's the advantage of doing the genetic testing before planning next pregnancy. The case for 26 years old, non-consanguineous marriage, second gravida, first full-term delivery, a stillbirth female in village, cause not known, 26 weeks. Patient was referred to me. Blood group was positive. Now this is another case which I have put specifically. I'm giving the ultrasound findings first. This was referred to me in a railway. I'm also a consultant in a Central Railway Hospital in Mumbai. So the patient was referred there from a periphery, and it was showing the hydros fetalis. As you can see, there was a pleural effusion, ascites. So it was a non-immune hydros fetalis, but that was not the only finding. The cardia looked okay. There was no structural defect in the heart which was found, but there was one thing which was very, very conspicuous, and that was, if you look at the heart rate, it was very, very fast heart rate. If you can look at the heart rate, it's mentioned here, it's 220. Persistently, the heart rate was 220, which is very high, right? So, and the atrioventricular rate, both were very, very high, 220. So, this was non-immune hydros fetalis with 220, 230 heart rate, 1-to-1 AV conduction, no other structural cardiac defect. So, this was a case of supraventricular tachycardia. Now, whenever there is, I have deliberately put the history afterwards, but we always look at the history first. So, this particular patient had a pile of papers with her. So at 14 weeks from the periphery from where she was coming, her thyroid TSH was 0.01. So the obstetrician referred the patient to a physician, And the physician repeated the thyroid function test. Again, the thyroid TSH was 0.02. And the physician put the patient on the anti-thyroid drugs, putting the diagnosis of hyperthyroidism, carbimazole or neomerkezole 5 mg OD. After that, after 6 weeks of starting that, at 20 weeks, the TSH became normal. So the both physician and obstetricians were happy. But suddenly at 26 weeks, they picked up head drops, for which the patient was then referred to Mumbai Railway Hospital. Now, here at Railway Hospital, we repeated the thyroid function test in an NABL accredited lab, which did show TSH again low 0.01. The T3 and T4 were marginally high. So it was a diagnosis of maternal hyperthyroidism. So now in the Railway Hospital, the diagnosis was confirmed NIHF with SVT because of maternal hyperthyroidism. Now, the patient was referred to the physician and pediatric cardiologist for antiarrhythmic treatment of the mother. This is fetal therapy basically, because we want to control the SVT by giving antiarrhythmic drugs to the mother. So patient was admitted in the ICU of Railway Hospital. Flecainide was started under the guidance of pediatric cardiologists, where the patient stayed for 5 days, and look at the dramatic result. The fetal heart rate reduced from 220 to 160 in just 5 days of antiarrhythmic treatment or fetal therapy. Now, the story goes on. The patient didn't want to stay more in Mumbai, wanted to go back to its place. So they took DAMA. Ideally, antiarrhythmic treatment should have been continued, but they took DAMA, went to the village, and under physician's treatment continued carbimazole. Now, I followed up with the patient to know what was the outcome. At 34 weeks, the thyroid function test in the mother were okay. Not only that, look at the ultrasound. There was dramatic change in the ultrasound picture. The high drops had completely resolved and the fetal heart rate was 150. There was no cystic lesion in the abdomen, no fluid, no high drops whatsoever, with the fetal heart rate of 140 at 35 weeks, 4 days also. Now, if you look at the maternal findings, we would find that there should be some maternal findings of hyperthyroidism. But the only positive finding was some tachycardia, 106. That's it. Otherwise, mother had no symptom, no sign. All the reports, investigations, everything was normal. Patient was just on the neomerkezole 5 mg OD. And at 36 weeks, they gave a short trial and that LSCS was performed and 2.4 kg baby was delivered. And day 3, the thyroid function tests of the baby were normal. Baby's heart rate was 140, right? Now, I presented this case in Jabalpur from where the patient had come after some time. And one obstetrician got up and said, "Madam, this was my patient. And now the baby is 1.5 years old and doing well." So it was so good to get the follow-up right from the obstetrician there. Now, why I have discussed about this case here is that we know that the normal range and everything is known to us for the thyroid. What is important is to be able to pick up this kind of cases, that in this particular case, TSH was low, but the T3, T4 were not very high. Still, high drops occurred. Maternal symptoms of hyperthyroidism were not pronounced. Still, high drops occurred. So, what we should learn from these cases, TSH is still gold standard. And in first trimester, if we find that the TSH is low, we must do thyroid function test in NABL and ISO accredited lab. We all know that lab to lab, the results also differ. So we must send the thyroid function test in the NABL or ISO accredited lab. And if the TSH is low with high T3, T4, even if it is borderline, we must refer to endocrinologist for treatment, because hyperthyroidism is something which needs proper physician or endocrinologist treatment. Not only that, ultrasound surveillance of the fetus is very, very important, because we don't want the fetus to go till hydrop stage. We want to pick up in between and intervene in between. So we have to look at the fetal heart rate. If it goes beyond 180, we know this is not well controlled. If the fetus is developing goiter with vascularization, if it is more central, it is showing hyperthyroidism. Of course, if it progresses further, it would go for hydrops fetalis, but I would like to pick up before that. And the worst case, there is cardiac failure, tricuspid regurgitation, A-wave reversal in DV. I don't want to go to that stage. I want to pick up before that. I want to control this before that and prevent this cause. So what is important here is that had we not gone into details of the investigation and what is the cause and didn't find out the cause, looking at the picture, it was at 26 weeks, hydrops fetalis, non-immune hydrops fetalis. If termination would have been done without finding out the cause, we would have lost the baby also. And in next pregnancy also, we wouldn't have been able to help the patient. So what is important is try and investigate properly, right from history to all investigation to ultrasound, reach to the cause, treat the treatable. There are many other causes of treatable NIHF also, like parvo B19 infection. We know that there is transient anemia, so a single intrauterine transfusion is going to help us. Pleural effusions or large pulmonary cysts leading to non-immune hydrops fetalis, thoracocentesis can help us. Fetal ascites, peritoneal amniotic shunt can help us. So fetal tachyarrhythmias, as we saw in this case, fetal therapy with antiarrhythmic drugs does help. Teratomas, chorioangiomas, pulmonary sequestration, ultrasound-guided laser coagulation of feeding vessel does help. Twin to twin transfusion is an altogether different topic, but there also laser therapy, etc., helps. So, meaning thereby, these days, the fetal diagnosis, ultrasound, fetal therapy, everything has evolved a lot. So we're able to pick up more and more causes. We're able to treat the treatable causes, help the patient to save the baby. We don't want the fetus to go on also to this stage of non-immune hydrops fetalis. We want to pick up before this and try and treat, and if possible, prevent this. So I would like to say that we all say this, I'm not the best, but I am trying my level best. So with the help of ultrasound, rest of the investigations, we should try and reach to the cause and try and find out the cause, treat, and help our patients, because we are ultimately interested in the best of maternal as well as fetal outcome as an obstetrician. So with this, I would conclude my talk, and thanks for patient hearing. I'll just humbly request here that I'm going for the post of Vice President Foxy from West Zone. The election will be in August, so do vote and support. Do take out your 1 minute for online voting and do support. I was chairperson Foxy Imaging Science Committee for 3.5 years, and throughout my tenure, my aim was to make ultrasound reach to each and every obstetrician. Everyone should be able to either do or interpret ultrasound well, because that's something we badly need, right from early pregnancy till term. For every case, we need ultrasound, and therefore we must learn to either do it on our own or to be able to interpret it well to help all our patients. Thanks for patient hearing. Thank you.
Thank you, Dr. Bela, for such a brilliant talk. And you made it so simplified, taking us through the journey of immune hydrops fetalis to the non-immune hydrops fetalis, and with the case-based scenario, which has greatly enhanced the learning and enlightened the speakers about the audience about the causes of non-immune hydrops fetalis, especially the case scenarios at 12 weeks, the NT scan done, wherein it one of the cases was trisomy, and then it could be Turner's, and then it could be infection, it could be parvovirus infection, it could be genetically acquired conditions like the arthrogyrosis, wherein both the parents were tested. And such is the beauty of our stepwise evaluation of the case scenarios, that definitely it will go on to help in a long way. And very rightly pointed out that many a times we are in a dilemma when we find that there is a hydrops at 20 weeks, 22 weeks, 24 weeks, whether we should advise the termination for this patient, and then careful evaluation will definitely throw light. I had one patient who was my OPD assistant, and I found that she was about 24 weeks with hydrops fetalis. We were really worried. And when we investigated and treated her, she went on to have a term pregnancy and a nice male child at 38 weeks of gestation. So such are the case scenarios wherein one should not be put off the balance or guard, that when we find a hydrops late in mid trimester, that let us, and especially in a RH positive patient, let us make a sustained effort to see that we thoroughly investigate the patient in lines of whatever has been discussed so far, the congenital causes, the genetic causes, the infective causes, and inherited chromosomal disorders, wherein it can go a long way to help the patients and the babies to see that we come with a very good outcome. Extremely well presented case scenarios, and we are very happy that we had a very good audience as well. More than 80 logins we found. That means to go to show that the topic is of such significance. We all know what to do in RH negative, that is hydrops fetalis, but non-immune, yes, definitely it's a challenge and scratching the head for everybody. Thank you so much for the wonderful deliberation, and all the best wishes for your candidature, and we sincerely hope that may the best one win. Thank you so much.
Thank you so much. Thank you. Thank you, Dr. Rajesh, for those kind words.
Bharti ma'am? Bharti ma'am, would you like to give any comments? I don't see any questions in the chat box. If any of the delegates wants to ask.
Suma, before that, you ask the comments from Dr. Durgadas and both the patrons, if they are there online.
Nagraj sir? Nagraj, Hiremat sir?
Yeah, I'm there. Thank
Sir,
you.
your comment, sir.
Yeah, thank you, Bela. Such a wonderful talk, especially your case number 4. The way you have followed it, the way you have reached to the baby even at the age of 1.5. And the problem was very simple, thyroid dysfunction. Because we find thyroid dysfunction so common nowadays and we don't take it so serious. But every inch of it you have taken so serious and you have followed it. Congratulations for giving a nice baby to that mother. And we would like to appreciate your work as a imaging science, the chairperson. Really, you have done a wonderful work and you deserve to go high up in the Foxy. And we wish you all the best for your coming election. And especially we have covered so well about non-hydrops fetalis. Thank you, Bela.
Thank you, sir.
Thank you, sir.
Good thing you reminded me at 6 p.m.
Yes. I wanted to have blessings of you all today, sir.
Durgadas sir, your comments, please. Shobha ma'am? I request Ballad sir to give.
Shobha ma'am is there.
Yeah. Of course, I have heard Bela speak many times. Every time she excels in the topic. And I have already posted in the chat box. After Bela took over, the committee suddenly started a lot of activity, became very dynamic. And a lot of obstetricians started following her sessions, and more interest in training for ultrasound has come about. And I think, Bela, you have connected very well to societies. And you have not been loud on the WhatsApp groups, but we can see that you have touched base with many practitioners in the country, many Foxians. And certainly that effort will be rewarded, is what is my conviction. And I hope that success is yours. Let us hope that you really get a good number of votes. And today, the very fact that KCOG has created the platform and supported by KCOG and Hiremat sir is there, and there is a little kind of history in Foxy that when sir is supporting, the candidate doesn't lose.
Thank you so much. Oh my God, that means a lot.
So we will not say that too loudly because nazar drishti agbardu ant ಹೇಳ್ತೀವಿ ನಾವು. Okay. Okay, so sir has been known to always kind of,
Shobha, let us be proud that we select the right candidate.
Yes,
Yes, yes,
that's what I
yes.
was about to say. Correct. Yeah, earphones. Yeah. So that is how it goes with KCOG. We are very united. We are very vibrant in academics. We really encourage very good talks, and today was an example for that. I think Rajeshri is there. Please take Rajeshri and Suman's this thing also, Suman. Okay.
Yeah, there's one point which about the fourth case, like hyperthyroidism, like when we are talking about evaluating the case, like routinely we do the TSH values, and at what cutoff value do you advise that the patient should further be evaluated, and which is the accurate parameter, the free T3, T4 or just the T3, T4? And is there any particular instruction we give to the patient regarding the fasting sample, or such practical points which wherein it does matter in terms of evaluation and giving the proper line of action?
So what is very important is that the cutoff values that we take as per ATA are 0.1 to 2.5 in the first, 0.1 to 3 in the first trimester, 0.2 to 2.5 in the second, and 0.3 to 2.5 in the third trimester. So anything in the first trimester less than 0.1 TSH, at least, as I said, first check whether you have done it with a ISO accredited lab or NABL accredited lab, because we have seen various difference in the levels. You also must have seen in your lab to lab difference in the levels. So it has to be a standard lab, one thing. And then once you find that this is something abnormal, get a complete thyroid function test done from the standard lab. And if that also shows that combination of little high T3, T4 and this. Now, again, for T3, T4, total value is important because the binding globulin to this T3, T4 increases in pregnancy. So if you just look at the free hormones, the level may not be very high. So you have to look at the total T3, T4. And if it is high and the TSH is on lower side, then obviously it's best thing to consult either an endocrinologist or a good physician who can treat hyperthyroidism in the mother properly. Of course, there is also roles of antibody titers and all that, but this was from the periphery where they couldn't do it. But in this particular case, there would have been some antibodies against TSH, which has gone from maternal circulation to the fetal circulation and led to all these problems. So what is important is first do a basic workup from a standard lab, look at the values, and then refer to a specialist. As far as for hypothyroidism we can treat, but hyperthyroidism is best treated by a specialist. And then, as I said, I would always keep an eye on the ultrasound markers to see if the hyperthyroidism is really under control, because we may feel that the levels are okay, but the antibody may be playing something different, and therefore we must the ultrasound markers will give us the clue whether the treatment is going on properly or not, and then we can prevent actually the hydrops from happening itself.
So, Dr. Bella, what investigations, suppose we find that on doing the ultrasound, say at 18 weeks of gestation, we find a hydrops, what would be the role or what would be the line of investigation and evaluation for such patients? Does torch have any role in this hydrops, non-human?
Yes. So So in my list of causes I had enlisted. So there are so many causes, as I said. But what we do is, see, we look at the history first of all. If we have any pointers in the history, one thing. As in this case, patient had some reports, so we had some clue and we looked at the report and could find out that
exactly.
So history is extremely, extremely important. One thing, as I said, in the one case that I showed, there was a history of neuromuscular disorder in previous 2 babies also. So we know that here there is some recurrent genetic cause which is there. So we always look at the history first. Then if you do not have anything positive in the history, yes, I'm going to look at first of all, whether it's immune, non-immune, I'll look at the blood group of the mother. If it is positive, again, ultrasound can give us lots of clues. So we look at the markers for any chromosomal or genetic defect. As I said, suppose for Down syndrome, we have 9 soft markers at 18 to 22 weeks that we look at when we do the anomaly scan. We have markers for torch infection as well. But again, the torch infection is very, very tricky. So the markers may be just calcification in the brain, in the liver. Hydrops would come little later, and then again, it's tricky in the sense that the torch, the signs may come later in the the late
Second
second
trimester.
trimester. So
Or
torch
early
is
third trimester.
extremely very, very, very difficult to tackle antenatally. So basically on ultrasound, we try and find out any markers for infection, any markers for genetic syndromes, or we look at the growth centiles, because growth centiles falling below third centile is also marker for a genetic cause. We look at the Dopplers for sure, to kind of MCA-PSV Doppler will tell us whether there's anemia, which could be one of the cause because of any reason, PARO-B19 or genetic cause. So putting together the history, all the ultrasound findings, whether any structural defects in the, as I said, in cardiac defects or mediastinal masses also can lead to non-immune hydrops. So we rule out the structural defects, we rule out all the markers, we look at the blood investigations, look at the thyroid function test, and try and kind of reach to it. If we do not find any cause pointers on this thing, ultrasound, or from the reports, of course, we will tell the patient amniocentesis followed by microarray and DNA storage and torch. Both things are important in case of non-immune hydrops, because we may rule out the genetic cause then, but then the torch PCR is also important on amnio, especially in non-immune hydrops, because that could be the only marker of torch infection in this particular baby. So the
in your experience, which is the most common period of gestation when you find hydrops, when you are coming across non-immune hydrops fetalis?
So I have picked up many cases at nuchal, as I showed in this. At
Yes,
nuchal,
yes.
also have seen genetic cause and
Yeah,
all
but
may come earlier. And as I said, torch infection, etc., it may come little later. Even for this immune hydrops also would come little later in gestation, second half. Earlier, genetic causes are common, more common than
and
torch.
torch infection, we also find that there could be IUGR also with torch infections.
Parvo-B19 is one, which may come up little earlier. Yes, around third, fourth month. Also, we may find even alpha thalassemia. You may find around fourth month or so. But rest of the infections, cytomegalo and toxo and all, may come up little late after.
Later in pregnancy, yeah. And we also see that most of these toxo infections, etc., are associated with IUGR.
That's what. So early onset IUGR would be pointer for genetic cause or even the torch infection.
Okay.
Bharti ma'am?
Thank you so much. Thank you.
Please. Bharti ma'am? I see Dr. Vidya, but on the screen. Dr. Vidya?
Yeah.
Dr. Suman Gaddi is also there.
Suman ma'am?
Yeah, good evening, one and all. First of all, I would like to congratulate Dr. Bella for Madam's brilliant presentation and bringing up such wonderful case discussions. And Madam has stressed upon the advantage of doing genetic testing. Counseling before the testing is very, very important. And suppose this the index pregnancy is affected, then the importance of workup before the next pregnancy is very, very important. And of course, I like that, saying reach to the cause, because you should identify and treat the treatable. That is, of course, the solution to the non-immune hydrops pregnancies. So thank you very much, Dr. Bella, and all the best for your candidature for your ensuing elections. Thank you.
Thank you, ma'am. Bela ma'am, there are a lot of appreciations for you in the chat box. I don't see any questions, so that itself will say that you
Dr.
have
Suma,
made
can I
everything
have,
clear.
can you
clear.
permit me for one question, Dr. Suma?
Yeah.
Yes, sure.
Madam, excellent presentation. Otherwise, also in concerns to the MCA value, which you're mentioning, and we rightly do a Doppler at 16 weeks to find out fetal anemia. But our radiologist always tell us that if it is mild anemia, usually the velocity does not change. So do you feel that we need to actually repeat again at 18 weeks or conclude it then?
4 to 6
So
weeks.
we are, as we know, that MCA PSV we would do at 16 weeks only in the cases where your ICTT titer has crossed critical level. That is one thing, right? Otherwise, we wouldn't advise MCA PSV even at 16 weeks. Or if in past pregnancy, the stillbirth because of this had come had was documented little earlier. So only in those cases we would do at 16 weeks. Now, if it is normal at 16 weeks, yes, we must repeat it at 18 to 20 weeks also, because if the titer is positive, if the ICT is positive, ideally we have to repeat it 1 to 2 weekly, because anytime in between the MCA-PS we may cross 1.5 mmol and we may need to do transfusion as early as 18 to 20 weeks as well. So positive, yes, weekly ideally should be repeated.
Yes. Thank you, ma'am.
Okay, sir, now I request Bellad sir to give his final remarks.
Yeah, thank you, Dr. Bela and all the KCOG colleagues. Dr. Vidya, before I say, Vidya Bhatt is there, please ask her to give her comments.
Dr. Vidya, I would like to hear from you as well. I can't see madam, though.
I called her, sir,
Madam
but
is logged in.
she has logged in,
I
but
think she's busy.
Okay.
Vidya,
Okay.
ma'am, are you there?
even I called her, but she's not
Yeah.
answering.
I think
Sir,
I
your comments,
sincerely,
please.
yeah, I am okay. Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, Dr. Bela, it was a wonderful presentation. See, I just want to say that the earlier the fetal hydrops in pregnancy, we should rule out the chromosomal abnormalities. I mean, this is the recommendation which comes from the NIH. I request all the delegates to go through, and if anyone has read maternal fetal medicine textbook from Creasy Resnick, 7th or 8th edition, there is a full page on causes. But you get lost in that causes. So what is the, you gave the nice approach, but that is given in the diagnostic approach there. If it is the first trimester or early in pregnancy, usually the chromosomal or genetic abnormalities are noted. And if it is a little later, infective, because even torch or other group of investigations, they manifest little later. And then the storage disorders or the metabolic, that is Gaucher's disease and others, they still manifest little later. So when we are evaluating these, and also most important and very treatable approach, we should, as you mentioned in your thyroid case, actually we should do that antibodies. They similarly act, the like how the Rh isoimmunization antibodies, they act on the fetal RBCs. So that is why the how this fetal tachycardia, actually there is some entity which describes there, the why this tachycardia and other cardiac abnormalities also cause. I had a question only on, because we should, whether we should first think of the treatable causes. For example, we should rule out, like if it is a chromosomal abnormality, straight away you can terminate if it is done. Whereas the infective pathology, especially parvovirus, one, as you mentioned very clearly on that, single transfusion can, cure that illness. Like this, our approach on this, because we had seen 3 cases of non-immune hydrops. Unfortunately, the patients could not afford on this, and the what they recommend is, if we are unable to find the cause, in such cases, though termination is offered to them, but the serum or amniotic fluid can be kept to find out any storage disorder which are not usually evaluated. I want your comment on that, especially the storage disorders which are very difficult to tackle because we have markers for infections, we have markers for the chromosomal and genetic, because complete exome testing will put out the clear diagnosis, whereas the metabolic disorders like Gaucher's glucose 6 phosphatase deficiency, they are little difficult unless we go into micro level. Do you agree? And I want your comments on those.
Thank you for bringing out that point, sir. That's a very relevant point because whenever we are not able to find out any cause for non-immune hydrocephalus based on whatever investigations we have done, whatever ultrasound findings are there, it's very, very important that the rare causes or whatever which is not detectable till now should be now looked at. So the sample from either the amniotic fluid if the patient allows, or even if you terminate the fetal tissue, DNA storage is extremely important. Why? Because this DNA can be stored in the genetic lab for the a period of 2 years, and they charge nominally for that. Now, sometimes the patient is not ready for investigating on the same because of the cost, because of the trauma that they have to go through for the termination, etc. They are not ready for the investigation. These are expensive tests. But at later date, maybe after 3 months, 6 months, they can be counseled that we can test on the same before they plan the next pregnancy. Now, on the same DNA, we can look for the genetic causes, for the metabolic causes, because basically there'll be some mutation which is leading to this. So, based on the whatever findings which are there, so geneticists always say that ultrasound, fine, yes, you can find out, but sometimes you may miss some of the things on ultrasound. So best thing would be fetal autopsy. Now, even if you can't do fetal autopsy, fetal photographs, X-rays, and DNA storage, all things put together can help the geneticist to arrive to a conclusion for the cause, one thing. And ruling out if all other genetic causes, then based on the history and genetic counseling, if they can pinpoint to some of the metabolic causes, then of course the DNA of the same which is stored in the lab can be tested for the same, and that would help. But so there's a major role here of the geneticist, the clinical geneticist, a good clinical geneticist, because only they'll be able to try and find out from the pedigree chart and history and the family history and everything whether there can be some metabolic disorder in this particular baby. Yes, sir.
Yeah, thank you so much. And it's a wonderful presentation. And I hope the people enjoyed. See, we want to reduce NMR to less than 12 by SDG and MMR less than 93. I mean, in India it is, but to reach to 70, we need to approach those conditions which we were not been able to prevent earlier. We can do that now. So in that way, when you are vice presidentship, when you get elected, probably concentrate on how our women can be safer and how our healthy babies are born. So I think with that, even our next president of KCOG is here. She is Rajeshri. That we should ensure that Karnataka will not be north of South India. It should be on par with other states of southern India. So we should work
Yes, sir.
on this. And when
Sure.
I was recently there with the Dr. Rajkumar on the maternal mortality reviews, many of the deaths are preventable still in this state what they are happening. So we all let us work, Bela, with your vice presidentship and next the president Rajesh Palladi to ensure Karnataka's and all Indian women and babies are born healthy, because any country is considered developed only when the mother and the children are safe. Madam, men are useless on this, so that is why when developed world we to say that the woman and the children should be safe in that particular country. So we have reached fourth economy, but we are still not called developed world because our women and our kids are not yet safe like in developed world. So we wish you all the best and we support Bella, for your candidature. Okay. And I thank all my KCOGians and KCOG colleagues for their support. And we had a good number of people who joined.
Yes,
And
yes,
I
yes.
I just want to assure Rajeshri that our next webinar will be with Dr. Frank Lewin, who is
Okay, sir.
president of FIGO Next, who's taking over from Jean Conrad.
Excellent.
I am going to meet him in sometime October, but before that, I may plan his webinar. So
Excellent,
thank you
sir.
everyone,
Thank you, sir.
and thank you all the KCOGians and KCOG friends.
Thank you, sir.
Thank you, sir.
So
Thank you
much,
so
Dr.
much.
Bellard, for your wonderful interaction and your pulse of wisdom. And your wishes and blessings mean a lot to me. On personal note, it is very good experience for me to be here with KCOG and KCOGA. I think I haven't been connected to KCOGA for quite a long time. So it was really indeed a pleasure here to be with you all here, with all seniors, all stalwarts of KCOGA and KCOG, and your friends. So many of them I can see are still there. Dr. Shobha Good is still there. Dr. Sonia, Dr. Rajeshri Palladi, the incoming
Thank you.
chair. So thank you so much for giving me this opportunity here today to be with you all. And thanks for blessings and wishes.
So
Thank
you
you,
all the
ma'am.
best. All the best. Thank you.
Thank you, ma'am.
All the best, Bella. All the best.
Thank you.
Bella, sir, shall we go for vote of thanks, sir?
Yeah, that's what I wanted you to tell them.
Okay. I would like to thank the speaker of today, Dr. Bella, ma'am. Ma'am, it was really an excellent and indeed a very nice talk, ma'am. And all the best for your future Foxy election. I thank the chairpersons of today's talk, Bharti ma'am and Rajashri ma'am, for chairing the session. I thank the office bearers of KCOGA, Nagraj sir, Hiremat sir, and the president of KCOGA, Durga Das sir, and Secretary Shobha Gudi ma'am and Shobha Bembalgi ma'am, and also the Dean of KCOG, Bella sir, especially for giving me this opportunity, and Secretary of KCOG, Dr. Sonia Mandapa, and Chairperson, Dr. Vidya Bhatt, and also the Treasurer of KCOG, Dr. Suman Gaddi. I also thank all the delegates, and actually the number was almost 85, and that too at this time. So I thank all the delegates for attending this webinar. Thank you one and all. And good night from
Thank
our
you.
side. And I also
Good
thank the
night.
technical staff, Mr. Arun, for helping